Good morning. This is Dr. Sandeep Patwardhan, pediatric orthopedic surgeon, and I'm going to talk to you today about children's ankle fractures, a case-based approach. Children's ankle fractures are really not managed very well because most of them are seen by general orthopedic surgeons, and they tend to treat them like adult ankle fractures. So let's see what are the differences and how to manage them. This is a 10-year-old boy with this kind of an ankle injury, which was diagnosed by a general orthopedic surgeon as a medial malleolus injury. So how would you manage this? There are four options: either a closed reduction or a cast, a closed reduction and K-wire, closed reduction and a cannulated screw, or an open reduction TBW, which people tend to do for a medial malleolar fracture. Now this is what the surgeon did. Question is this good enough? Is this okay? If you look critically at this particular X-ray, you can see here that there is an intra-articular step, and in addition to that, there's a single K-wire which has been passed. Unfortunately, he left the wire in for 6 months, and this is what the child ended up with: a fascial bar and a growth arrest, creating trouble for him for the future. So let us talk about what is this type of fracture. Okay, if you see, there are two components to this fracture. There is a medial component and then there is a lateral component. This is classified by a modified Log-Hansen classification as supination inversion injury. There are two stages of the supination inversion injury. In the first stage, there is a fibular injury, which can be an ankle sprain, an antenatal injury, or more commonly, it's a type 1 epiphyseal separation from the distal fibular physis. And then the talus moves into adduction, and there is a push-off fracture, which crushes the fascial plate, and that is a Salter type 4. Okay, so this is a stage 2 injury, and this is the complete injury for a supination inversion force. So this is what happens. There's a Salter 4 there, there's a Salter 1 on the fibular side. The easiest way to remember this is the deformity, which is clinical. So deformity in supination inversion is always a varus angulation. So if you see a child's foot and ankle in varus, you can be assured this is a supination inversion injury. What are the stages of treatment? The deformity needs to be reversed, as we saw here. How do we do that? We can do a closed reduction. But does the treatment end here because it looks good on X-ray? Is this stable enough? So this was treated with a cast, and you see what happened. 4 months post-injury, again, there is an articular step. It did not heal very well in anatomic position and caused trouble. So this is totally not acceptable, right? There is a step there, and we need to fix these fractures. This will cause a fascial arrest and an articular incongruity. So after you get a satisfactory closed reduction, the next step would be to fix it. There are vertical shear forces acting at the fracture. Transepiphyseal pins is not the best way to put because we need compression. So what you need to do is put a compression screw which is completely intra-epiphyseal. This can be done percutaneously. So that is how you do it. The next thing is, what is the quality of your reduction? So after the reduction and stabilization, we need to do an arthrogram. Okay, so you put some little dye in the ankle and you will see the joint line very well. So establish articular congruity with an intraoperative arthrogram that will tell you that there is no step and your articular congruity has been well maintained. And the final thing is, after healing, always look for fascial injury or fascial recovery, as it's called. So you can see this Park and Harris growth arrest lines. If these lines are parallel to the original physis, there has been a temporary cessation but no bar and growth has recovered. If they start converging to a certain point, then probably there is a bar happening and there will be a growth deformation which will need further attention. So always follow up fascial injuries for long term, at least 1 year, so that you know what is happening. What about the fibula? Once you fix the medial side, do you need to fix the fibula? After you fix the medial side, you do a stress test. So test it. If it is adequately stable, just a cast is enough. If it is not, you can pass a smooth pin and stabilize it. So an example, a comminuted type 4 intra-articular with fascial injury. aspiration of the hematoma, as you can see here, an arthrogram which shows you the articular step, the Salter 4 injury here, and the Salter 1 injury on the fibular side. And then restoration of the articular congruity, a percutaneous guide pin, cannulated screw fixation, and you can see the accuracy of reduction as seen in this particular arthrographic picture. And you can see such a small incision and everything is perfectly aligned. Let's move on to the next type of injury. The second type of injury in children in the ankle, again clinically, is going to be a valgus deformity with external rotation. So this is called pronation, eversion, external rotation injury. This is also very peculiar and it has its own peculiarities which I will highlight. The pathology here is the tibia is a Salter 2 injury. A Salter 1 can also happen, but it's usually a Salter 2. But the fibular fracture is always metaphyseal and extra-articular. The soft tissue injury here, as you can see, the deltoid the periosteal flap can get incarcerated when you reduce this. So remember that there is a large periosteal flap attached to the distal tibial fragment. What about the fibula? I mentioned earlier, this is extraphyseal, metaphyseal or diaphyseal green stick fracture. So just looking at the fibula also you can make out what kind of injury you are dealing with. In the earlier varus supination inversion, it was a physeal injury type 1. Here this is metaphyseal or diaphyseal, extra-articular, extraphyseal. The deformity, as I mentioned, is valgus angulation. So if you see a valgus deformity, it's a supination external injury. How do you treat them again? Most of them are treated by close reduction. And once you get reduction, if they are not stable, you have a large metaphyseal fragment, put a couple of metaphyseal screws. The fibula is conserved with a cast. Usually that doesn't need treatment or plating. Transmetaphyseal screws. What about unstable fractures? In this situation, if you need to put a smooth pin, always aim for the center. A pin which goes through the center will cause minimum growth arrest, and even if it happens, it will be symmetrical. So in case you are passing a wire instead of a screw, it's a Salter 1 injury instead of a 2 injury, and screws are not possible. You can pass a smooth pin, but aim for the center and remove it as early as possible. So this is an example where 2 pins have been used. What is the commonest complication? An imperfect reduction. And why does that happen? I mentioned earlier a periosteal flap. Is there something interposed? The commonest thing is a periosteal flap, and other soft tissues such as the neurovascular bundle and the tibialis posterior tendon can also get trapped in this particular type of injury. So if you get an imperfect reduction, there is something blocking it. Then you will need to open reduction, bring out the periosteal flap. Then you put your pins. That is the periosteal flap you can see, which was incarcerated, and the smooth pins have been passed to stabilize the fracture. And then you can suture it. So again, if you see here, the metaphyseal fragment has been fixed with a screw, and epiphyseal, you put smooth pins. Don't cross the physis with threaded screws. Always pins across the physis. Example of a PEER injury, you can see the valgus deformity, the metaphyseal fracture of the fibula, then removal of the incarcerated periosteum, smooth pin across the physis, and a cancellous screw across the metaphysis. Early removal of the K-wire, as you can see, the 2 pins which were here were removed, screw remained for a longer time, everything healed very well. So moving on from the valgus type of injury to the third injury. What is this pattern? Here you can see a tibial fracture, which is a spiral fracture going from proximal to distal. This is called a supination external rotation fracture pattern, where the leg lies in external rotation. So it's a spiral torsional fracture where the tibia fails first in the stage 1 and the fibula fails second in the second part of the injury. Unlike adults where the fibula fails first and the tibia fails later. So stage 2 is when the fibula fractures. Okay, so always look for the fibular fracture. This is a long spiral fracture and the leg is in external rotation. It's a metaphyseal fracture going across, and it's a spiral fracture. It's not comminuted. Note in pediatric age group, fibula always fails after the tibia. What is the deformity? It's external rotation. So look at the leg. Is it lying in external rotation? Also, if you see just a spiral fracture of the fibula, beware of that fracture, because the tibial fracture can be a Salter 1 injury which you will miss. So if you see closely on the lateral view, there is a mismatch between the distal tibial epiphyseal plate and the articular plate. So you can see that it is translated. Just a fibular fracture which is there, spiral, should alert you to the possibility of having a tibial physeal injury which is type 1. Look at this, a fibular fracture here, and you can see widening of the physis here. So this is a Salter 1 injury in the tibia. Beware of these fractures. The fibular fracture is obvious, but the tibial may be innocuous. So you should always look for it. Look at the clinical picture. If you see the clinical picture, you'll see that the leg is lying in external rotation, right? That will tell you that this is a supination external rotation injury. What do you do about this? Just correct the rotation, right? And everything closes. So reverse the mechanism, internally rotate the distal fragment to close the fragments, after which if it is unstable, you can put metaphyseal screws or just a cast. What are the other things? The lateral X-ray is important. If it's a tibial physeal type 1, correct the translation. If there is translation, again you will be in problem. So you just need to pull the fragment a little forward occasionally so that the translation is well corrected. That is how it should be. If it is unstable or severely swollen, put metaphyseal screws to hold the metaphyseal fracture. Moving on from that, what is the fracture pattern in this fracture? You can see here that the distal part of the physis has gone in plantar flexion and the shaft of the tibia has translated anteriorly. So again, this is a special fracture which is called supination plantar flexion. So you have the two components here where the tibial is a Salter Harris 1 or 2 and the distal fragment always in plantar flexion and it translates posteriorly, whereas the anterior distal metaphyseal tibia translates anteriorly. So that is what happens. The fibula again is metaphyseal and it is green stick. So the overall deformity here is posterior translation with equinus. These fractures are again treated by anterior translation and cast immobilization. Reverse the deformity. The translocation needs to be corrected. Bring things in their original position. Always flex the knee while doing this reduction so that the gastroc is relaxed. Push against the anterior tibia. And once you get a reduction, you can put transmetaphyseal cancellous screws. Let's move on. If you see this X-ray closely, it looks normal. But if you see very, very closely, there is a small fragment which has got avulsion. Now this is a special fracture. This is called the Tilu fracture. This is special because it is intra-articular and intraphyseal. And it always happens in adolescents. Doesn't happen in younger children. So any girl between 11 and 13 or a boy between 12 to 14, looking at this X-ray, get a Mortise view. Diagnosis is usually missed. That small fragment is overlapping. So juvenile Tilu fracture is an avulsion fracture of the distal tibiofibular ligament. It's pulled off, it's intra-articular and it's intraphyseal. So obviously this needs accurate anatomic reduction and fixation. How are these fractures managed? With an accurate open reduction, or if you can get a good close reduction, a percutaneous screw to compress it and get an arthrogram. So an example of a 12-year-old boy with a Tilu fracture, and you can see this large fragment. Always get a CT scan done for adolescent fractures because that will define the fracture better for you. That is the anterolateral screw which has been put and an arthrography should be done. Let's move on to one more special fracture before I complete this talk. And this mimics a Tilu fracture on the AP view, but if you take a lateral, you see a metaphyseal fragment. So it looks like a Salter 1 injury on the plane AP, but on the lateral, it looks like a Salter 2 injury, but actually it is a triplane fracture. Okay, so triplane fractures are special fractures. What are the three planes in a triplane fracture? You have a sagittal fracture going through the epiphysis, then a horizontal fracture going through the physeal plate, and a vertical metaphyseal fracture going into the distal tibia. So there is a sagittal epiphyseal fracture, and this is how it goes. There is a horizontal physeal fracture across the physeal plate, and then there is a coronal metaphyseal fracture. So there are three different planes which are interconnected. What are the treatment protocols? How do you do a close reduction? What is acceptability? Do you need to open? What is the approach? And other options. let us talk about these. So look at this fracture. Again, you see a Salter type 3 injury here, which is intra-articular on the AP. What more information do you need? You get an information on AP that there is one fracture line. Then you get another lateral X-ray and you see translation and a metaphyseal fracture here. So you have a second fracture line. Now the horizontal one you can see has been seen here because of translation. So this is a classical triplane fracture. Now with these X-rays you have established that this is a triplane. Now you need to get a CT scan done so that you see the alignment. So when you get a CT, you get a cut through the epiphysis and through the metaphysis. Let me show you those. So the cut through the epiphysis will show you a sagittal fracture plane with two fragments rotated outwards. That's fragment 1 and fragment 2. Okay, but the fracture line is in the sagittal plane, right? Whereas the metaphyseal cut of the same fracture is going to show you a different picture. So if you see the metaphyseal cut, now you see that the fracture line is in the coronal plane and you have an anterior fragment and a posterior fragment. So the fracture plane here is coronal. Why you need this? Because you need to know the orientation of your screws, right? So when you do your reduction maneuver, you put a couple of pins in the epiphyseal fragments. With these two pins, you derotate. When you derotate and make them closed, advance those pins. Remember, your pins are in the epiphysis. The same maneuver is closing the metaphyseal fracture. You don't need to do separate incision or separate maneuvering here. Those pins are closing this because it is connected to each other. Remember, the pins are in epiphysis, but the same manipulation will close your coronal fracture plane simultaneously. But the screw in the metaphysis has to be antero-posterior for a lag effect, and the screw in the epiphysis has to be transverse. So this is the final result. You will have a transverse screw going across the epiphysis, and you will have an antero-posterior screw or a couple of screws in the metaphysis. This is how the fracture fragments need to be fixed. This is how you do the surgery, and then you should do an arthrogram. Always an arthrogram to make sure the articular congruity is good and your result will be perfect. An example of a 13-year-old boy with a triplane fracture, you can see the CT scan, the coronal plane in the metaphysis, the sagittal fracture in the lateral. And this is how you fix it. AP screws in the metaphysis, transverse screw in the epiphysis. So let me summarize for you. There are 6 types of fractures in children. The first one is supination inversion, where you have type 1 injury in the fibula and a type 4 injury in the medial malleolus. Then you have pronation eversion external rotation, which is a valgus injury, where you have a metaphyseal fracture of the fibula and a large fragment, there could be periosteum incarcerated. Third one is a spiral fracture with external rotation, supination external rotation. Finally, you have supination plantar flexion where there is equinus. So clinically look at the leg. If it is a varus, it's type 1 supination. If it is valgus, it is valgus injury, pronation eversion external rotation. If you have external rotation, it's supination external rotation. And if you have equinus and plantar flexion, it's a translation. And then you have 2 special adolescent fractures, the Tilou fracture and the triplane fracture, which completes the 6 fractures that happen in the adolescent and the pediatric ankle. Let's go back to the ankle which I showed you earlier, that K-wire. Look at this K-wire which has been left inside for 6 months, which has caused a focal fascial arrest. So you get an MRI, find out that there is a fascial bar here and there is an overgrown fibula. About 5 years of growth is remaining. So what did we do? We did a metaphyseal osteotomy. We went and excised the fascial bar. I put in a fat graft here. Then we shortened the fibula, took the graft from the fibula, put it here on the medial side. That is the bar being removed using burrs and the fibula being shortened and plated. You can see this chunk of the fibula being put here as an opening wedge. The fascial bar has been excised, fat graft has been put. Over a period of time, that is how it consolidates. That is its appearance and function at 14 months. And that is after complete healing at maturity. So we could correct everything without any problem. Finally, let me invite you to a special fractures conference for pediatric fractures, something that we call iFix. International Fractures in Children Symposium. We have been doing this since 2012. This year it is in Jaipur. You will learn everything that you need to do in your practice about children's fractures. This is the exclusive premium fractures conference for children's fractures. So please join us 23rd to 25th of August 2019 at Radisson Blu in Jaipur. Thank you very much for your attention.